am Dr. Vega, and I am one of the teachers of Emergency Focus. I live in Australia, and I really want to teach you how to understand the visual field effects. This topic is quite difficult sometimes, a little bit tricky to understand, and it will come up in your med school exams if you are a medical student, or if you're doing any general medicine exam. For example, the ones to get you registered in Australia or in other country. So the visual field effects are a very important and hot topic, and I have a really good way of making it easy for you. Before we start, I would like to acknowledge the traditional owners of the land in which I live, the Biripi people, and pay my respects to the elders past, present, and future. Let's get started. Let's start with a little bit of an understanding of my diagram. On the top, we can see a representation of the visual fields, okay? After that, I have a little representation of the rest of the anatomy of the visual pathway. The human visual system will begin with the globe, which is this representation of these two circles. The nose is in the center, okay? Specifically with the sclera, the uvea, and the retina, okay? We have a temporal side and a nasal side here as well, and I'm representing that the information from the nasal visual field, for example, the right eye, will be captured by the temporal side of the retina. Okay, the retina forms the sensory layer and contains the rods and the cones. These specialized neurons synapse with the bipolar cells, which then signal to the ganglion cells, and the axons of these ganglion cells will get all the way together at the optic disc and form the optic nerve. Okay, so in this diagram you're going to see two parts of the optic nerve, the nasal fibers, which are in purple, and the temporal fibers, which are in green. After that, the fibers of the optic nerve will go all the way. The nasal fibers will cross over in the chiasm, okay, in the optic chiasm. This means that the nasal fibers from the right eye will end up transmitting information from the temporal visual field all the way to the other side, to the occipital cortex on the left side. Okay, so this also means that the optic tract, for example, of the right eye, will be formed by the nasal fibers of the left eye, right, of the left optic nerve, and the temporal fibers of the right optic nerve. Very good. After that, the fibers of the optic tract will course posterolaterally around the cerebral peduncles to synapse in the lateral geniculate nucleus, okay, of the dorsal lateral thalamus. And from there, we're going to have something called optic radiations. I'm not going to get into details of the visual defects of the geniculate body. We're going to go from optic tract to optic radiations. They will divide into superior and inferior, and then together again converge and get all that information from the visual field all the way into the occipital cortex, okay, and the occipital lobe, the visual cortex. Very good. So this is the representation, very, very basic, so don't expect any more details, okay? This is for undergrads and very general medicine exam. Right. I want you guys to understand the way that I am describing the visual fields. This is very important later on to understand the name of the visual field effects. There is a way of calling the visual fields, okay? This will be a representation of the visual field. We have one way of doing it and another way of representing it, but it's the same. So on this side, we can call it nasal side of the visual field of one eye or the other, and temporal sides of the visual field of one eye or the other. The other way of understanding it as well is to say, okay, well, for example, this is the left side of the visual field of the left eye, right? And for example, this will be the right side of the visual field of the right eye, right? That's easy. This will be the left side of the right eye, and this will be the right side of the left eye. Great. Quick concept that we need to remember. First one is that if we are understanding, let's take the left side of our visual pathway, in which I am talking about the temporal fibers of the optic nerve of the left eye that will capture the information from the nasal side of our visual field of this eye, and then the nasal fibers, right, of the right eye of the optic nerve that will capture the information from the temporal visual field of the right eye. Okay, I'm just describing what we have in front of us. The nasal fibers will decussate and cross over in the chiasm, then we'll end up together with the temporal fibers of the other eye. What is the meaning of this? The meaning of this is very easy. If we see it on this other representation of the visual field, we can see that R and R means right. So the right side of our visual field on both eyes, that information will always be processed by the left occipital cortex, okay, and vice versa. So, what do we have here? As we said before, let's talk about now the right side of the visual pathway, okay? So, we are considering the nasal fibers of the left eye that will give information from the temporal visual field of the left eye, and it will cross over in the chiasm, go all the way into the occipital cortex. On the other side, we have the temporal fibers of the optic nerve. In this case, they will transmit the information from the nasal visual field of the right eye. All of these, they both together, will end up in the right occipital cortex. Very, very simple. What can you see here? L and L. So that means that the left side of the visual field of both eyes that information will be processed by the right occipital cortex. The last two quick concepts that we need to remember. Let's just remember that the temporal fibers of the optic nerve on both sides, so we're just talking about these green lines, these green temporal fibers, will carry the information from the nasal visual field, so the opposite. Temporal fibers, nasal visual field of both eyes, and they will transmit that information all the way to the same side in the occipital cortex. At the same time, if we're talking about the nasal fibers of, for example, the optic nerve, we need to see how the nasal fibers will transmit the information from the temporal side of the visual field of both eyes. So nasal fibers will transmit the information from the temporal side. And in this case, because they cross over in the chiasm, the right nasal fibers from the right optic nerve will end up all the way into the left side of the occipital cortex, so the left one, and the left nasal fibers from the optic nerve will end up on the right occipital cortex. Let's see what happens if we have damage of the optic nerve. Very important to remember that any damage that will happen above the chiasm, it will give us only damage or impairment of the eye, of one eye. That's called monocular. Any damage that includes the optic chiasm or below will impair both eyes. So we'll have some sort of blindness if it's binocular of both eyes. Let's consider there is a damage on the left optic nerve. What would happen? So this patient won't be able to see on one eye. Okay? So what is happening here? The patient is blind on one eye. How do we call that? Anopia. Anopia. Ipsilateral, so when we talk about ipsilateral, contralateral in visual field effects, they are talking about the damage. But when we are calling or describing the actual problem, the actual visual defect, we have to describe the visual defect. Left anopia, left blindness of the whole eye. Okay? And it's the same size, so that means that the left optic nerve is impaired. This can happen due to different reasons. Some of them are ischemic reasons, for example, in patients with hypertension, diabetes or dyslipidemia. Sometimes this can happen with non-ischemic optic neuropathy, arteritis, for example, in giant cell arteritis, or in young patients in optic neuritis. Now let's see what happens if we have an impairment in the optic chiasm. Remember, anything in the optic chiasm or below will give us an impairment of both eyes, binocular. Let's remove the temporal side of it, so the green lines, and only remain with the ones that are affecting the optic chiasm, which are the nasal fibers, in this case of the optic nerve. The ones that, as we said before, what is happening here? They are taking the information, capturing the information from the temporal side of our visual field. Because this information cannot be transmitted all the way to the cortex, what is happening? This person can't see from the exterior part of their visual field. How do we call this? Temporal, bitemporal. But what is happening? I want you to see how we got an L now and an R now. What is the meaning of this? Well, the left side of the visual field of the left eye is impaired and it's different from the other eye, because in the other eye, which is the right eye, it would be the right side of the visual field impaired. So how are we going to call the visual field? We have to name the visual field defect. The temporal side of the visual field will be impaired on both sides, on both eyes. So bitemporal, heteronymous. Why heteronymous? Well, can you see the L and the R? That means that on one hemifield, so on one visual field, it would be in the left eye, the left side. But on the right eye, it's not the same side impaired. It's not the left side impaired. It is another side, the right side. So if I have impairment on different sides of both eyes, of both visual fields, I have to call it heteronymous because it's different sides on both eyes of both visual fields. Look, I know this can be tricky, but it's not. It's basically, if you see the L and the R, you see that the left side of one eye is damaged, it's impaired, and the other one is right. It will be called heteronymous. And the last one is hemianopia. What is the meaning of this? It's just telling me that this patient is not completely blind of the whole visual field. It's only half of it. Hemi means half. So half blindness. In total, optic chiasm damage will give us bitemporal, heteronymous, hemianopia. Let's now see what happens when we have damage in the optic tract. Okay, so remember, we'll have a binocular visual field defect. It will affect both eyes. Consider that we have a damage on the left optic tract. I have removed the other side of the visual pathway that we don't need it at the moment. So remember, left optic tract. Do you remember what we said at the beginning? That the right side of the visual field of both eyes, that was going to be processed by the left occipital cortex? Well, this is the same. Okay, the right side of the visual field will be transmitted by the left optic tract and all the way into the left occipital cortex. Right, so what is happening here? I am going to describe the blindness. So let me describe the blindness. What is happening here? I have right, because it's the right side of both visual fields of both eyes that is impaired. Do we agree? We can see an R and R. So that's called right. Great. What's next? Is it the same side of both eyes? Yes. So how do we call it? Homonymous. Right? Homonymous. And how much of the visual field is affected? Half of it. So how do I call it? Hemianopia. So in this case, a damage on the left optic tract will give me a right homonymous hemianopia. Now, when you see this contralateral homonymous hemianopia, it's just telling you about where the damage is. So if I have right side blindness of both visual fields, that means that it's contralateral. So it means that the damage is on the left optic tract. This can happen due to vascular causes, which are the most frequent in adults, and in children, neoplasms. Let's see what happens now in the optic radiations. They will divide into two sides, so superior and inferior optic radiations. Remember that it's below the chiasm, so we're going to have a binocular visual defect. It means that both eyes will be affected. Let's consider the left inferior optic radiation damage. To make it easy, let's remove the other side of the visual pathway. So I said the left inferior optic radiations. We are on the left side. We're going to talk about the inferior optic radiations. And pretty much we can see what is the meaning of this. So can we see now how I have pretty much divided my whole visual field into 4, we can say 1, 2, and if I trace another line here, it will be 4, 3, and 4. So this person somehow has an impairment on the left inferior optic radiations and is not able to see on the superior right side. Great. So what is the meaning of that? So the meaning of that is that the superior visual field information will be transmitted by the inferior optic radiations all the way into the occipital cortex. But these inferior optic radiations go through the temporal lobe. There are so many questions that will ask you if there is a damage in the temporal lobe, what type of visual defect this patient will present, and you have to answer that. And it's very, very easy. So the temporal lobe will be the one that will have these inferior optic radiations, which are the ones that transmit the information from the superior visual field. And because we said at the beginning that anything on the right, so anything on the right side of my visual field was going to be processed by the opposite side, the damage will be always contralateral. So let's just first describe what we're seeing. Let's name this visual field effect. Remember, I said name the visual field effect, so we have to just describe the blindness. So this would be right, because it's the right side of both eyes, right side of the left eye, right side of the right eye. Cool. What else? Superior, because it's only the superior part. So right, then we have superior, and we have homonymous. Homonymous means that it's the same side of both eyes. So right, homonymous, superior, and now it's a quarter. So we call it quadrantanopia. And to take home, what is the most important thing? Through the temporal lobes, the inferior radiations, optic radiations go through, which are the ones that carry the information from the superior visual field. And we know anything on the right side of the visual field will be processed by the left side of our visual pathway, of our cortex. So if I have this blindness, I know that it's somewhere on the left side. And if I have it superior, I know it's somewhere on the temporal lobe, and it's somewhere on the left inferior optic radiations. Practice this, go back if you need to. Consider that we have a damage on the left superior optic radiations, left superior. Okay, so what do we have here? Now this patient is presenting a right side blindness of only a quarter and on the inferior part of the visual field on both eyes. So what's happening here? Well, the same thing, but we just need to understand that the inferior visual field information, okay, from the inferior part of the visual field, will be transmitted by the superior optic radiations, and they go through the parietal lobe. Okay, so this means that any defect in the superior optic radiations or the parietal lobe that is affecting these radiations will cause this type of blindness. And how do we call it? Let's describe it. So we describe the blindness. So it will be right. Is it same side? Yes, right side of left eye, right side of right eye, so homonymous. Is it superior or inferior? Inferior, so right homonymous, inferior. And is it a quarter? Is half? Is it total? It's just a quarter. So how do we call it? Quadrantanopia. Very good. So right homonymous, inferior, quadrantanopia. In the exam, you're going to have, or your exams, different type of questions regarding this, and they will tell you about the parietal lobe. So if there is a damage in the parietal lobe and this patient is presenting some sort of blindness, it will be this type of blindness. Another way of calling it is just by telling you that the damage will be contralateral, okay, as we said before. In general terms, damage in the optic radiations will give you contralateral because it's the other side. The origin of the damage is on the other side of the visual field defect. If it's the right blindness, then it's the left side. Homonymous, same side. Inferior or superior, depending if the inferior optic radiations or superior optic radiations have been damaged. And then quadrantanopia, because it's only a quarter. We're almost done. So we're going to have a look again at the occipital lobe, the visual cortex. This is very, very similar to the optic tract, but with a little difference. Why? Because now the information is not going to be divided into superior and inferior optic radiations. Now the information comes all the way together as well. And consider that we have an impairment on the left occipital cortex. Well, you just need to remember, very easy. I have removed the other side of the visual pathway that we don't need. So what is happening here? The same as it was happening when we had the optic tract damage. We have now, if it's the left side, a right side blindness. Is it the whole eye? No, only half. So it's just already telling you that this is going to be called right, because it's the right side of both eyes. Homonymous, because it's the same side of both eyes, right? Hemianopia, because it's only half of the visual field that is impaired. And up to there is the same as in the optic tract, impairment. But now we have this blue dot. I tried with this blue dot just to show how the macular part of my visual field will be preserved. So this person will be able to see through this blue dot, okay? This is the interpretation. So what is happening? This person is going to have a right homonymous hemianopia with macular sparring. So any damage in the occipital cortex will give you a contralateral. We're talking that the visual field defect will be on one side, and the opposite side will be where the origin is. If it's right here, right side of the visual field on the left eye and right side of the visual field of the right eye, then, as we said at the beginning many times, the damage will be then in the left occipital cortex. And if we have this macular sparing, we're talking about the occipital cortex. There are a few different hypotheses about this. One of them talks about the fact that the macula has a vast area in the occipital cortex, and it might be also supplied by a different artery. There are many different hypotheses, but this is one of them. Great, so that's it. I hope you liked it. I hope you understood. Please go back and forward and feel free to watch this as many times as you need. If you liked it and you want to know a little bit about our courses, let us know. If you want to subscribe, I will be posting more videos free for everyone to understand very soon. Thank you and have a good day.